London, 1869. A young woman walks into a doctor's office on Harley Street, her hands clasped tightly in her lap. She's trembling, not from illness, but from shame. Her husband brought her here. He says she's too emotional, that she cries without reason, that she's been reading novels again, those dangerous romantic stories that fill women's heads with improper thoughts, that she seems distracted, restless, unhappy with her domestic duties. The doctor listens with grave concern, nodding as he makes notes in a leather-bound journal. He asks a few questions, discreet, clinical questions about her sleep, her appetite, her monthly cycles. Then he delivers his diagnosis with the certainty of modern science. Hysteria. She's suffering from a disease that's reached epidemic proportions among Victorian women, a condition that threatens her sanity, her marriage, and her very soul. But there is hope. Medical science has developed treatments, procedures, cures. What follows is one of the strangest, darkest, most absurd chapters in the history of medicine. A chapter where pleasure was pathologized, where female bodies were systematically controlled, and where doctors waged war on women's sexuality while calling it healing. This is the story of how the Victorian world declared war on female pleasure and disguised it as medicine. The diagnosis that doctor delivered didn't appear out of nowhere. It had roots that stretched back thousands of years, through centuries of misunderstanding, superstition, and male anxiety about female bodies. Ancient Greece, around 400 BCE, Hippocrates, the father of Western medicine, proposed a theory that would shape medical thinking for the next 2 millennia: the wandering womb. According to this theory, the uterus wasn't a fixed organ but something almost alive, capable of moving throughout a woman's body like an internal parasite. When a woman exhibited emotional distress, irrational behavior, or physical symptoms that physicians couldn't explain, the diagnosis was simple. Her womb had wandered from its proper place and was wreaking havoc on her system. The prescribed treatment, marriage and pregnancy, sexual intercourse would anchor the womb in its proper position. Childbearing would satisfy its natural purpose and keep it stationary. A woman without a husband, without regular sexual activity, without children, such a woman was medically vulnerable, her womb liable to drift and cause all manner of problems. The Romans adopted this theory wholesale. Pliny the Elder wrote about the uterine fury that could overtake unmarried women. Galen described how the retention of female seed could poison a woman's system, leading to hysteria. The word itself derived from the Greek hystera, meaning womb. This wasn't just bad science. It was a medical framework that made female sexuality a matter of male control. A woman's health depended on marriage, on male sexual access, on fulfilling her reproductive purpose. Female desire independent of male partnership wasn't just improper, it was medically dangerous. The Middle Ages added another layer: religious condemnation. The Christian Church took the ancient medical theories and baptized them in moral judgment. Female desire became not just a medical problem but a spiritual one. The body was a site of temptation, and female bodies, with their mysterious cycles, their capacity for pleasure, their dangerous fertility, were especially suspect. Medieval texts are filled with warnings about female carnality. Women were portrayed as more susceptible to demonic influence, their bodies gateways through which evil could enter the world. Sexual desire in women wasn't natural or healthy. It was evidence of corruption, of Eve's curse, of the fallen nature of femininity itself. By the Renaissance, the medical and religious perspectives had fused into a single worldview. Female sexuality was dangerous, needed to be controlled, and any woman who exhibited sexual agency or emotional intensity was fundamentally disordered. But it was the Victorian era that would take these ancient anxieties and dress them in the respectable clothes of modern science, creating a systematic, medicalized approach to controlling female bodies that would be more thorough, more invasive, and more damaging than anything that had come before. By the 19th century, the old myth of the wandering womb had acquired a new coat of respectability, the authority of scientific medicine. And doctors were ready to weaponize it. To understand the Victorian war on female pleasure, you first have to understand the culture that made it possible. a society simultaneously obsessed with and terrified of sexuality, a world where repression was elevated to the status of virtue. Victorian Britain and America worshipped at the altar of respectability. The ideal society was orderly, moral, controlled. Every emotion regulated, every desire restrained, every impulse subjected to the iron discipline of proper behavior. And nowhere was this more true than in expectations of women. The Victorian feminine ideal was the angel in the house, a phrase from a popular poem that came to define an entire gender ideology. The perfect woman was pure, passive, self-sacrificing, and above all, devoid of sexual desire. She existed to soothe men's baser natures, to provide moral guidance, to create a sanctuary of calm domesticity. Advice manuals for women, and there were hundreds of them, spelled out the rules with excruciating specificity. A proper lady moved slowly and gracefully, never rushed or exhibited physical vigor. She spoke softly, never raised her voice, never contradicted men in public. She dressed modestly, covering every inch of skin except face and hands. She read only approved literature, religious texts, moral tales, perhaps some carefully selected poetry. Novels, especially romantic novels, were dangerous, liable to inflame the imagination. And sex was a duty, something to be endured for the purpose of producing children, not enjoyed. The most influential marriage manual of the era, written by Dr. William Acton, stated unequivocally that the majority of women, happily for them, are not very much troubled with sexual feeling of any kind. This wasn't just Acton's opinion, it became medical orthodoxy. Victorian doctors genuinely believed, or at least publicly claimed to believe, that normal, healthy women didn't experience sexual desire. Any woman who did was, by definition, abnormal, diseased, in need of treatment. But here's the profound hypocrisy at the heart of Victorian society. While publicly condemning sexuality, they were privately obsessed with it. Pornography flourished. Prostitution was rampant. London alone had an estimated 80,000 sex workers by mid-century. Upper-class men maintained mistresses while insisting their wives remain pure and ignorant. The double standard was breathtaking. Male sexuality was natural, inevitable, impossible to fully control, regrettable perhaps, but understandable. Female sexuality was unnatural, dangerous, a sign of moral corruption that required intervention. This created an impossible situation for women. They were expected to be sexually available to their husbands. Producing children was their primary duty, but also sexually unresponsive. Too frigid and you failed as a wife. Too passionate and you were diseased. And doctors became the enforcers of this impossible standard. The medical profession, overwhelmingly male, positioned itself as the guardian of female moral and physical health. Physicians became the arbiters of what was normal, what was acceptable, what required treatment. Any deviation from the narrow band of acceptable female behavior could trigger medical intervention. A woman who was too intellectual, dangerous strain on her delicate nervous system. Too ambitious, unnaturally masculine, possibly hysterical. Too emotional, classic hysteria. Too unemotional, also hysteria, a different variety. The diagnosis was infinitely flexible, applicable to virtually any woman who failed to conform perfectly to Victorian ideals of femininity. But when repression became recognized as sickness, when the strain of maintaining that impossible standard manifested in physical symptoms, headaches, fainting spells, anxiety, insomnia, medicine found a profitable cure. And that cure, in its most common form, was stranger and more ironic than you could possibly imagine. The standard medical treatment for hysteria in the Victorian era involved a procedure that was performed thousands of times in countless doctors' offices for decades, and yet was never openly acknowledged for what it actually was: pelvic massage. The theory went like this: hysteria was caused by a congestion of fluids in the female reproductive organs, a buildup of nervous energy that needed release. The treatment was for a physician to manually massage the patient's external genitalia until she experienced what doctors called hysterical paroxysm, a sudden release of tension accompanied by involuntary muscle contractions, flushed skin, and a sense of relief and relaxation. In other words, orgasm. Doctors were giving their female patients orgasms and calling it medicine. But here's the truly remarkable part. There's substantial evidence that Victorian physicians genuinely didn't recognize what they were doing as sexual. The cognitive dissonance was so complete, the denial so thorough, that they could induce climax after climax while maintaining absolute conviction that this was a purely medical procedure, no different from setting a broken bone or lancing a boil. The procedure would begin with the patient lying on an examination table, her skirts raised, her legs positioned for access. The doctor would apply oil to his fingers and begin massaging the vulva, focusing particular attention on the clitoris, though medical texts often avoided naming it directly, referring instead to the sensitive tissues or the anterior region. Sessions could take a long time, 30 minutes, an hour, sometimes longer. The patient's response was the goal. Increased breathing, flushing, involuntary movements, and finally the paroxysm itself, after which she would report feeling calmer, more relaxed, her symptoms temporarily relieved. And relieved they were, not because the treatment addressed any actual disease, but because these women, many of them trapped in sexually unsatisfying marriages, taught that their own desires were shameful, forbidden from even touching themselves, were finally experiencing sexual pleasure, perhaps for the first time in their lives. The treatment was wildly popular. Women returned for regular sessions, sometimes weekly or monthly. Doctors' waiting rooms filled with hysteria patients seeking their therapeutic massage. It became one of the most common medical procedures in urban practices. But it had a problem. It was exhausting for the doctors. Medical journals from the period contain complaints from physicians about the physical strain of performing pelvic massage. Caused hand cramping, finger fatigue, wrist pain. With multiple patients per day, all requiring lengthy sessions, it was genuinely arduous work. Enter mechanical innovation. In the 1880s, Dr. Joseph Mortimer Granville, a British physician, patented an electromechanical device designed to deliver rapid, percussive vibrations to the body. The Granville hammer, as it was called, was initially intended for treating muscle aches and general nervous complaints. But doctors quickly discovered it had another application. It could induce hysterical paroxysm far more quickly and with far less effort than manual massage. The medical vibrator was born. Within a decade, dozens of models were available, ranging from large clinical devices that ran on electricity or battery power to smaller hand-cranked versions. Medical supply catalogs featured them prominently. Advertisements in medical journals touted their efficiency and effectiveness. The language of these ads is remarkable. One manufacturer promised their device could bring a patient to the necessary conclusion in less than 10 minutes. Another bragged about the satisfying results and grateful patients. The sexual subtext is obvious to modern eyes, but apparently invisible to Victorian doctors, who continued to frame this as purely therapeutic technology. By the turn of the century, vibrators had become so mainstream that they were being marketed directly to consumers for home use. Advertisements appeared in women's magazines, Good Housekeeping, Modern Woman, presenting vibrators as health and beauty devices. Relieves tension, promotes feminine wellness, brings the glow of health to your complexion. Women could order them through male catalogs. Sears Roebuck famously sold several models. They were cheaper than a sewing machine, more affordable than many other household appliances. For the first time, women had access to reliable sexual pleasure in the privacy of their homes, disguised as medical treatment. The supreme irony is inescapable. Victorian culture, which had declared war on female pleasure, which pathologized female desire, which subjected women to horrific treatments to suppress their sexuality, that same culture inadvertently gave women a tool for sexual liberation, all because doctors refused to acknowledge what they were actually doing. The cognitive dissonance could only last so long. By the 1920s, when vibrators began appearing in early pornographic films, their actual purpose became too obvious to ignore. They disappeared from mainstream advertising, relegated to the shadows and the black market, where they would remain until the sexual revolution of the 1960s brought them back into the light. But not every woman's cure came in the form of mechanical pleasure. For many, the Victorian medical establishment had far darker treatments in mind. procedures designed not to relieve symptoms, but to eliminate female sexuality entirely. The vibrator represents the absurd, ironic side of Victorian medical treatment. But there was another side, brutal, deliberate, and designed to punish as much as to cure. For women whose hysteria was deemed too severe for simple massage, or for those suspected of masturbation, the cardinal sin of Victorian female sexuality, the treatments escalated from uncomfortable to horrifying. Institutionalization was often the first step. Asylums for the insane became warehouses for difficult women, those who were too emotional, too disobedient, too sexual, or simply too inconvenient for their families to manage. Getting a woman committed was disturbingly easy. A husband could have his wife institutionalized with nothing more than his own testimony and a compliant doctor's signature. Fathers could commit daughters. Brothers could commit sisters. No legal representation was required. No trial. No opportunity for the woman to defend herself. Once inside, conditions ranged from merely grim to actively torturous. Many asylums used restraints routinely: straitjackets, leather cuffs, canvas wraps that immobilized patients for hours or days at a time. The stated purpose was to prevent self-harm or masturbation, but the actual effect was dehumanization and psychological breakdown. Cold water treatments were standard practice. Women would be subjected to surprise ice baths, plunged without warning into tubs so cold they induced shock and hyperventilation. Or they would be strapped to tables while high-pressure jets of freezing water were aimed at their genitals. A procedure that was supposed to cool the blood and eliminate sexual feelings. Electric shock therapy emerged in the late Victorian period, initially touted as a wonder treatment. Electrodes would be applied to various parts of the body, including the genitals, and current applied until the patient convulsed. The theory was that this would reset the disordered nervous system. The reality was trauma, pain, and in some cases, permanent injury. But the most horrific treatment of all was surgical. Dr. Isaac Baker Brown, a prominent London surgeon and president of the Medical Society of London, became convinced that he had identified the root cause of female hysteria, epilepsy, and various nervous disorders: the clitoris. His logic, twisted as it was, had a certain Victorian consistency. If female problems stemmed from excessive nervous energy in the reproductive organs, and if that energy was generated by sexual stimulation, particularly masturbation, then removing the source of that stimulation would cure the disease. Beginning in the 1850s, Brown began performing clitoridectomies, surgical removal of the clitoris, as a treatment for hysteria and masturbation. The procedure was done with minimal anesthesia. Victorian medical wisdom held that women had higher pain tolerance than men. They didn't, and that some pain was actually therapeutic, a punishment for the sin that had led to the condition. The patient would be restrained, her legs held apart by assistants. Brown would use surgical scissors or a scalpel to excise the clitoris, sometimes including surrounding tissue. The screams could be heard throughout the building. Brown performed dozens of these operations, possibly hundreds. He published case studies claiming remarkable success. Women who had been rebellious, sexual, difficult became calm, compliant, properly feminine after the procedure. He presented this as medical triumph. What he had actually done was mutilate women into submission through trauma and the permanent destruction of their capacity for sexual pleasure. For nearly a decade, Brown's practice thrived. He operated on teenagers suspected of masturbation, on married women whose husbands found them too demanding, on women who simply exhibited too much independence or intelligence. The diagnoses were vague, the criteria subjective, the results permanent. Other doctors began adopting his technique. Medical journals published articles debating not whether clitoridectomy was ethical, but what the proper indications for the procedure should be and what surgical technique was most effective. It took a scandal to end Brown's career. In 1866, it emerged that he had been performing operations without proper consent, sometimes operating on women who had come to him for entirely different procedures, adding clitoridectomy without informing them in advance. Other cases involved women who had been brought to him by male relatives and given no choice in the matter. The Obstetrical Society of London expelled him in 1867, ending his practice. But note carefully why he was expelled. Not because clitoridectomy was wrong, not because it was mutilation, but because he had failed to obtain proper consent. Many of his colleagues continued to believe the procedure was medically sound. The practice continued, though less openly, for decades afterward. Cases of clitoridectomy for masturbation and hysteria were reported in England and America into the early 20th century. The last documented case in the United States was in 1948, within living memory, long after Victorian prudery had supposedly been left behind. These weren't isolated cases of rogue doctors. This was systematic, accepted medical practice discussed in textbooks, taught in medical schools, defended by leading physicians of the era. The message could not have been clearer. Female sexuality was so dangerous, so pathological, that it justified permanent mutilation. A woman's capacity for pleasure mattered less than her compliance, less than her proper feminine behavior, less than the comfort of the men around her. Yet even as women suffered under these brutal treatments, even as the medical establishment waged war on female bodies, cracks were forming in the wall of ignorance. A revolution in thinking was coming, though its arrival would be slower and more incomplete than anyone hoped. By the end of the 19th century, a young Viennese neurologist was developing ideas that would fundamentally challenge Victorian medical thinking about hysteria, though his revolution would be far from complete. Sigmund Freud began his career studying hysteria using conventional methods. He examined female patients, reviewed case histories, and initially accepted the standard medical explanation. Hysteria was a physical disorder of the female reproductive system. But the more cases he studied, the less sense the physical explanation made. He saw women with identical physiological characteristics, some hysterical and some not. He saw hysterical symptoms that had no physical cause, that appeared and disappeared based on psychological factors rather than bodily states. Working with his colleague Joseph Breuer, Freud developed a radical new theory. Hysteria wasn't rooted in the uterus or the nervous system. It was psychological, stemming from repressed memories, unresolved emotional conflicts, and, most scandalously, repressed sexual desires. The implications were revolutionary. If hysteria was psychological rather than physical, then the entire edifice of Victorian medical treatment was wrong. Pelvic massage didn't work because it relieved physical congestion. It worked because it provided sexual release. Institutionalization didn't cure hysteria. It often made it worse by adding trauma to whatever psychological distress the patient already experienced. And clitoridectomy? From Freud's perspective, it was not just useless but actively harmful, mutilating women while doing nothing to address the actual psychological roots of their distress. Freud's theory of hysteria centered on sexuality, but in a way Victorian doctors hadn't conceived. He argued that women were sexual beings, fully naturally sexual, and that the Victorian culture's systematic repression of female sexuality was itself creating psychological illness. Hysteria wasn't caused by too much sexuality, but by the toxic effects of denying and suppressing normal sexual feelings. This was genuinely radical for its time. Freud was arguing that the problem wasn't women's sexuality. It was a society that refused to acknowledge or accommodate it. The disease wasn't in women's bodies, but in the culture that pathologized their desires. His treatment approach followed from this theory. Rather than physical intervention, Freud used what he called the talking cure, allowing patients to speak freely about their experiences, their feelings, their desires. In bringing repressed material into consciousness, in acknowledging rather than denying sexuality, patients could find relief from their symptoms. Freud's ideas spread rapidly through European and American medical communities. By the early 20th century, psychology had established itself as a distinct field, separate from traditional medicine, with its own theories and treatment methods. The physical treatments of Victorian medicine, the massage, the cold baths, the surgical mutilations, gradually fell out of favor, replaced by psychological approaches. This was progress. Genuine, important progress. But, and this is crucial, Freud's revolution was incomplete and deeply flawed. For all his insights about female sexuality, Freud remained profoundly patriarchal in his thinking. His theories positioned male sexuality as the norm and female sexuality as derivative, incomplete. He infamously argued that clitoral orgasm was immature, and that mature women should experience only vaginal orgasm, a theory that would cause decades of unnecessary anxiety and sexual dysfunction in women trying to live up to an impossible standard. Freud's emphasis on penis envy, his belief that women were essentially incomplete men, his tendency to interpret female psychology through exclusively male frameworks. All of this meant that even as he liberated women from physical treatments, he bound them with new psychological ones. And his talking cure, revolutionary as it was, remained a form of male authority. The analyst, typically male, interpreted the female patient's experience, told her what her symptoms really meant, positioned himself as the expert on her own psychology. The dynamic of male doctor controlling female patient's sexuality had shifted from physical to psychological, but it hadn't disappeared. Still, the shift mattered. By the 1920s and 1930s, the worst of Victorian medical practice had largely ended. Women were no longer being routinely institutionalized for hysteria. Clitoridectomy had become rare and controversial. The vibrator had been revealed as the sexual device it always was. The war on pleasure wasn't won overnight, but the battlefield was changing. Women were slowly gaining the language to talk about their experiences, the framework to understand their desires as normal rather than pathological, the tools to claim ownership of their own bodies. But change in medicine and psychology didn't immediately translate to change in culture. The attitudes, the shame, the silence, those would prove far more durable than the specific treatments. Victorian morality outlived Victorian medicine by generations. Walk into a doctor's office today, and you won't find vibrators being prescribed for hysteria. The language has changed. The specific practices have evolved. Victorian medicine is safely in the past, a curiosity from a more ignorant age. Except it isn't. Not entirely. The logic of Victorian medical control over female bodies, the assumption that women's experiences are inherently suspect, that female pain is exaggerated or psychological, that women can't be trusted to understand their own bodies, that logic still echoes through modern medicine in ways that should make us profoundly uncomfortable. When a woman complains of pain and is told she's being emotional, that's Victorian thinking. When female patients report symptoms that are dismissed or minimized by doctors, when they're prescribed antidepressants instead of being tested for physical conditions, when they're told their suffering is in their heads, that's the legacy of hysteria still alive and well. Studies consistently show that women's pain is taken less seriously than men's. Women wait longer in emergency rooms. They're less likely to be given adequate pain medication. They're more likely to have their symptoms attributed to anxiety or stress rather than physical causes. And when it comes to reproductive health and sexuality, the double standards are even more stark. Viagra was approved by the FDA in just 6 months. Female sexual dysfunction medications took decades and faced far higher scrutiny. Research into female sexual pleasure lags dramatically behind research into male sexuality. We still don't teach girls about the clitoris in most sex education programs. The primary organ of female sexual pleasure is simply omitted from the curriculum. The language has evolved, but listen carefully and you'll hear Victorian assumptions embedded in modern speech. When we call women hormonal, we're echoing the Victorian belief that female biology makes women irrational. When we use hysterical as an insult, always directed at women, never at men, we're invoking the same diagnosis that sent thousands of Victorian women to asylums and operating tables. When women are told they're too emotional, when female anger is pathologized while male anger is seen as legitimate, when women's ambition is questioned in ways men's never is, we're still enforcing the Victorian ideal of feminine passivity and calm, and the silence around female sexuality persists. Women still grow up with less knowledge about their own bodies than men have about theirs. Female masturbation remains more taboo than male masturbation. Women's sexual pleasure is treated as less important, less natural, less worthy of attention than men's. The Victorian medical establishment created a system where female sexuality was inherently suspect, where women's bodies were sites of danger that required male oversight and control, where female pleasure was pathological. And while we've dismantled the specific machinery of that system, the vibrator prescriptions, the asylum commitments, the surgical mutilations, we haven't fully dismantled the underlying assumptions. History might have changed its vocabulary, but the language of control remains. It's more subtle now, harder to identify and challenge, but it's there in the gap between how male and female patients are treated, in the research priorities of medical institutions, in the casual dismissals of women's pain and women's pleasure. The Victorian war on female sexuality taught women to distrust their own bodies, to view their desires as shameful, to seek male authority to interpret their experiences. And that lesson, passed down through generations of mothers to daughters, reinforced by culture and medicine and religion, created wounds that haven't fully healed. Understanding this history, seeing it in its most extreme, undeniable form, helps us recognize its echoes in the present. Every time medical research prioritizes male bodies as the norm, every time female pain is dismissed as exaggeration, every time women's sexuality is framed as problematic or complicated in ways men's isn't, we're seeing the legacy of Victorian medicine still shaping our world. Return with me to that doctor's office in London, 1869. The young woman sitting before the physician, trembling with shame, diagnosed with hysteria because her husband found her too emotional. What was really wrong with her? Perhaps nothing. Perhaps she was depressed, suffering from the claustrophobic restrictions of Victorian domesticity, the lack of meaningful activity, the absence of agency over her own life. Perhaps she was simply human, experiencing the full range of emotions that humans feel. Today, we might recognize her symptoms as depression or anxiety, conditions we understand have complex causes and require thoughtful treatment. We might ask about her life circumstances, her relationships, her sense of purpose and fulfillment. We might offer therapy that actually listens to her experience rather than imposing male interpretation onto it. But in 1869, she was hysterical. Her womb was the problem. Her female nature was the disease. And the cure would be whatever men decided it should be, whether pleasure disguised as treatment or mutilation disguised as healing. The Victorian era's war on female pleasure wasn't an accident. It wasn't well-meaning doctors making innocent mistakes with the tools they had available. It was a systematic, deliberate campaign to control women's bodies and women's sexuality, to enforce a gender hierarchy through medical authority, to ensure that female desire remained subordinate to male control. They called it medicine, but it was power. They called it healing, but it was subjugation. They called it care, but it was cruelty. And the most insidious part? They convinced many women that they needed these treatments, that their own bodies were betraying them, that their desires were symptoms of disease rather than expressions of normal human sexuality. The control was so complete that women internalized it, becoming agents of their own subjugation, policing themselves and each other according to standards created by male authorities. In the end, the Victorian war on female pleasure wasn't about medicine at all. It was about fear of women knowing their own power, fear of female sexuality untethered from male control, fear of what might happen if women understood that their bodies were their own and their pleasure was their right. That war officially ended a century ago, but battlefields leave scars, and the landscape of female sexuality still bears the marks of that Victorian campaign. The shame, the silence, the sense that female bodies are somehow more problematic, more in need of management and oversight than male bodies. These are the unexploded ordnance of a war supposedly long over. We've come far. Women today have freedoms and autonomy that Victorian women could hardly imagine. But freedom isn't just about what's legally permitted. It's about what's culturally accepted, what's psychologically possible, what's free from the weight of historical shame. True liberation requires not just dismantling the machinery of control but excavating and exposing its foundations, understanding how deeply the assumptions run, recognizing how thoroughly the logic of Victorian medicine has been absorbed into our cultural consciousness. Only then can we begin to build something different. A world where female bodies aren't sites of anxiety and control, where female pleasure isn't shameful or suspect, where women are trusted to understand their own experiences and make their own choices. The Victorian era ended in 1901, but in some ways we're still fighting to emerge from its shadow. History isn't just about dates and events. It's about ideas, how they form, how they spread, how they shape entire societies, and how they persist long after their original context has disappeared. The Victorian War on female pleasure shows us how cultural beliefs can masquerade as scientific truth, how power can disguise itself as care, and how systems of control can be so thoroughly internalized that they become invisible even to those they oppress. If this journey through one of history's darkest chapters has made you think differently about how we treat female sexuality today, about what assumptions still linger, about what battles remain to be fought, then it's served its purpose. Subscribe to this channel for more deep dives into the histories that shaped our present, the stories that reveal how thoroughly the past lives on in our assumptions and attitudes. Hit that notification bell, because next time we're exploring another chapter where medicine, morality, and power intersected in ways that still echo through our lives today. Remember, the most dangerous ideas are the ones that feel natural, the assumptions so deep we don't even recognize them as assumptions. Understanding where they came from is the first step toward imagining something different. Until next time, question everything, especially the things that seem too obvious to question.